terms of medications, what makes it hard to think about medications is that the economics are so powerful that it's hard to get to the science underneath them.
Right.
So drug companies make a ton of money selling psychotropic medications, and evidence that they may not work as well as someone says they do, they have intrinsic motivations not to shine light on that. The other big deal, economics, comes, suppose you're running a state mental health system, and you're as responsible as you can be for all the needs of all the people in your whole state. What are you going to go with? Psychotherapy that might take several years, or a drug that might blow up a system, well, that too, but a symptom in a few weeks. They have intrinsic motivations to lean toward medication. There's nothing wrong with medication. The first day I worked in the psychiatric hospital, I walked in full of a young person's idealism, thinking like psychotherapy can do all this stuff, throughout the meds. And at the end of the first day is whatever eases the suffering, I'm all in favor of. Because when we talk about mental health problems, we're not just talking about the suffering of ordinary people whose life isn't what they want it to be. Not to diminish that in any way. My high-functioning people need therapy as much as anyone else does. But some people come to us with things that really are mental illnesses: major depression, bipolar disorder, schizophrenia, autism. We can help all of those things, but there were different categories of things that we're dealing with. One of the issues with medications is that when the hard nitty-gritty work is done to really see what the effectiveness is, it's often not as wonderful as we first thought. A few years ago, in 2008, an ingenious research team somehow got access to all the data from studies on the current generation of antidepressants, selective serotonin reuptake inhibitors, drugs like Prozac. They not only found the published studies, but they found the unpublished studies that were submitted to the FDA. Many of these studies were problematic in their methods, like they didn't do long-term follow-up, or they didn't study equal numbers of people of different ethnic and racial groups.
Was there some meta-analysis they conducted?
It was the grandfather of all meta-analyses.
Yeah.
It was really, really good.
Yeah.
And what they found is that there was no evidence whatsoever that any of these drugs worked better than water or random chance in people with mild, moderate, or major depression. And that's science at its best. Now, what that doesn't mean is that if I have someone who is overwhelmed with depression and we're making steady progress in psychotherapy, but they want, and I want for them, something that might break the back of the worst of the symptoms, that I wouldn't send them to a psychiatrist or a neurologist or a nurse practitioner to say, is there something you think might help? What I would want that person to do is a thorough initial evaluation. Most psychiatrists won't do it. They'll spend 20 minutes. Could you get to know someone in 20 minutes? No. So I have to refer people to the subset of medical or nurse practitioner folks willing to do a thorough, competent job, and the subset of that group who know LGBT mental health, and I can count them on less than my 10 fingers, you know, and it costs money because insurance generally won't pay for that. And so then you've sliced off most of our community.
Right.
But when that happens, with the patient's informed consent, then there are medications that certainly can be helpful. And we could talk a lot about medications, the ones that help with psychotic spectrum illnesses can certainly quell acute symptoms, and getting some relief from not knowing whether the world is real or not is no small thing. Take those medications over time and your brain will atrophy. How do you get informed consent from that?
Right.
With care, with heart, with thoroughness, and we do it. Or we don't do it. And if it's not happening, patients are in a very difficult plight. One of the issues for LGBT patients is going to be whether the physician that they see or the nurse practitioner they see knows us well enough and is working thoroughly enough to know about side effects that might be specific to our communities. Some common psychotropics cause vaginal drying, which has effects on both heterosexual and lesbian and bisexual women, but is something that a lesbian patient may or may not feel comfortable speaking about unless the prescriber, with compassion and knowledge, opens the doorway. Same thing about cancers, which are associated with some of the psychotropic drugs. There's a very commonly prescribed antidepressant that when it was rolled out by the FDA, as many drugs are, the accompanying advertisements were, "This is the greatest thing since sliced bread." But it rolled out in the age of the internet, so people would talk to each other over the internet, and over the internet patients said, "This is causing erectile dysfunction."
Yeah, right.
Something sometimes easier to say over the internet than like to the doctor in the white coat.
Right.
Is it happening to you? And huge numbers of men over the internet said, "Yeah, it's happening to me too." It was only after that that a team of researchers actually listened to what was going on over the web and said, "Gee, we maybe better investigate this." The outcome is that 60 to 70% of people who take this drug have erectile dysfunction. I know plenty of psychiatrists who talk one way about erectile dysfunction with straight people and another way when they talk to gay men, because, you know, who knows what we do? It's so mysterious. Right? I guess they failed 8th grade health or something like that. I don't know. So you got to do it. A very powerful problem with psychotropic, well, actually a non-psychotropic medication in the gay male community, one for baldness, I clearly have never used this product, is that it causes erectile dysfunction in a significant number of people who take it. And, you know, gay men are more likely than heterosexual men to use those products. If the doctor's not opening it up, we can cause harm that we don't need to be causing. So medications, they're great, they're complicated, and they need to be used in a context of prescriber-patient relationships where honest conversation can happen.
Right. One quick follow-up on that. You work a lot with children, and some of the psychotropics can be very powerful, antipsychotics in particular. But do you have any reservations or concerns about prescribing for, younger patients?
As a psychologist, I don't prescribe.
Correct.
I refer people to nurse practitioners and various kinds of physicians, child neurologists, child psychiatrists. And I put the nurse practitioners in not because of PC, but because they do a really good job.
Right.
And I'm glad that they're there. Most psychotropic medications, we have no research evidence about whether or not they work on kids, because there are huge ethical problems in doing the research. Do you say to the parents, we are studying this drug in children, your child may get it, they may not get it in a double-blind study. If they get it, we don't know what the consequences will be for their brain, their heart, their growth, their development. Please sign here. Those studies can be done. They've been done on one antidepressant, which is mildly to moderately helpful to some children with depression. None of the other drugs have been studied. That doesn't stop tens of millions of prescriptions from being written every year for psychotropics for kids. Why are those written? Well, sometimes they're written because a parent and a prescriber say, we don't know the safety issues. We know the intensity and severity of this child's suffering. If you're willing, we can try, and we'll follow it closely together. That's the right way to do it. And I work with lots of kids and teens taking psychotropics with that kind of informed consent and very careful monitoring. Most of the time when they're prescribed, no one goes through that process. And sometimes people come to a mental health professional for a third or a fourth or a fifth or a gajillionth impression, because the medication has caused a 100-pound weight gain in a 10-year-old and type 1 diabetes they're going to live with for the rest of their life. So we're in tricky terrain.
Right. Thinking more broadly now here, in general, how well do mental health professionals serve LGBT people? Put it another way, if an LGBT person were to randomly pick out a mental health professional, just Google something or old school hit the phone book, and what are the chances of finding a therapist who will serve them well, or perhaps even more to the point, someone who won't serve them well?
I wish the answer were a better one.
Yeah.
It's tough out there. I've been doing what I do for a while. I teach and I have a practice and have a reputation as a pretty competent, fairly senior person. Work really hard every day to deserve that. More than half of the people I see in my practice come to me after they tried something else and it didn't work. The number of people it didn't work with is disturbingly high, which is why the certificate is so important, to try to have an impact on training, on policy, on the systems that produce mental health professionals. I think in our program there is not one graduate student who gets to get their doctoral degree in psychology here without being trained to have depth of competence and sensitivity with LGBT populations, and I'm fiercely proud of that. But selecting someone at random out of the phone book, I wouldn't advise it.
As we all know, the Affordable Care Act is now the law. All of 2 weeks ago now, people have been able to start signing up for insurance via the state exchanges, and come January 1st they'll start receiving services through the program. And
not everyone, actually.
Not everyone, correct. Those who are eligible.
Right.
But
which includes people without immigration documents, and probably about 1/10 of the population, according to some estimates.
What are the implications for our community overall?
I think they're real mixed. And on the one hand, if the choice is between health care and no health care, absolutely health care. The quality of the health care, and in particular the mental health care, is unfortunately likely to be real problematic. Under the Affordable Care Act, people of modest economic circumstances, and you and I are talking in D.C. during the government furlough,
Right.
lots of such people out there, they're going to be able to afford bronze level plans. Under bronze level plans, in a good state, a liberal state, the deductibles are around $2,000. Someone making a modest income doesn't have $2,000. After that, the co-pays for mental health services are going to be beyond reach of most such people, at least for psychotherapy, maybe for medication, and we've covered that terrain. Having access to medication, yes. Being forced into medication as the only kind of mental health care, when it does not work as well, is psychotherapy for most people not okay. The other problem with the Affordable Care Act, and you know, I'm a consumer and I'm a provider. From the provider point of view, what most insurance plans set as the quote usual and customary rate unquote for psychotherapy can be maybe half the rate that a private practitioner in a jurisdiction like this needs to charge to be able to be the kind of thoroughly trained, up-to-date practitioner that they need to be. A restaurant wouldn't serve you a meal at half of the price because you said, like, I don't know, I'm part of a big group of people, say men who like to eat food, you know, just charge me half. That's what these plans are going to say to people. So I think the Affordable Care Act is a great first step. It's a problematic first step, and we're going to learn. And the only way you learn anything is by trying it and learning from it what it does and what it doesn't do. And I'm very active in professional associations that are going to lobby the heck out of Congress and the government to try to make incremental improvements in this thing. In our LGBT communities, the people most likely to be left out in the cold are not middle class people who work in universities like you and me. They're going to be people on the margins. They're going to be sex workers. They're going to be people who live fiercely happy, transgressive lives. They might well be people with HIV who nowadays in protocol-driven HIV care are being told, take your medicine, take your medicine, take your medicine, take your medicine, roll up your sleeve, time for your blood test, take your medicine, and there's no relationship. The relationship is part of the treatment. Everyone knows that intuitively. I know that scientifically. If the Affordable Care Act doesn't make space for doctor-patient relationships, where after the 10-minute check your blood, look down your throat, say, the doctor says, how you doing? What's going on? How's your relationship? How's your job? How's your stress? We're not going to get to where we want to get to. I want us to get to where we want to get to. And the certificate is going to help us get there.
Good. Very important perspective, and not one that a lot of people think about when they think about the Affordable Care Act. You know. One last question, and it's sort of a broad-reaching, sort of forward-thinking thing. What do you see as some of the cutting-edge issues regarding LGBT health, mental health, moving forward?
Well, you know, a short list. We have families. That's like a growing, burgeoning thing. My LGBT students think about getting married. They see my wedding ring, they want one too. They think about children, not always, but often. Both options are fine. We're in the first generation of learning in depth about that. We're in the first generation of figuring out how to be queer, out, and old. I'm figuring out that in my own life. You know, there's a lot of things that we need to understand about that. We have a generation of long-term HIV survivors. What do we do to empower them to have full, rich, good lives? There's a psychological component to that, as well as a medical component to it. My sense of where mental health needs to go is, now that we know more than we did before about the kind of psychotherapy that gives people the best results, how do we figure out how to take that on the road, how to make that widely available, how to refine it, how to improve it? The only reasonable goal is for everyone on this planet to have a good, self-determined, empowered life. We're not going to get there in my lifetime, but we need to know together that that's where we're heading, and not stop until we're there.
Great. Dr. Richard Ruth, thank you very much.
You're very welcome.
Great.
It's been a pleasure.